Joining us today, here to talk about something that certainly has had no shortage of airtime, patient support programs. Between panel yesterday, focusing a little bit more on sort of the future-looking aspect of patient support programs in terms of data, like how do we use these patient support programs? How can they be a relevant source of informative data that guides our access conversations moving forward? Lots of conversation in the last session about patient support programs as well in terms of biosimilars and the experience that we've had across the country so far to date. The angle that we're going to try to take here today is a little bit different in terms of sustainability. So I think we've talked a little bit about the role of patient support programs in terms of filling healthcare system gaps, but we're going to articulate that a little bit more over the course of the conversation, but then take that sustainability angle a little bit further in terms of the programs themselves. And as a PSP operator, this is certainly a conversation I have often with partners in terms of the cost. This is a unique aspect to Canada relative to the global market, and being able to understand why this is important, I think is very important to be able to articulate. But also, now that we've been doing this for 20 or 25 years, whatever it's been, how do we reframe the conversation around patient support programs moving forward? What's critical? How do we create some excess capacity with these programs and use that to sort of either change the focus or fill new gaps, add more value to the conversation moving forward? So very quickly, I'd just like to ask each of these panelists to introduce themselves, and then we'll dive into the conversation. Quinn, maybe you can start.
Hi, I'm Quinn Grundy. I'm a registered nurse and an assistant professor in the Faculty of Nursing at the University of Toronto. And the focus of my current research is really trying to get the lay of the land and understand the landscape of patient support programs and private infusion care in Canada, and whether that's working, how that's working for the key stakeholders.
Perfect. Andrea?
Hi, everybody, again. Andrea Jaray. I head up our patient support services at Alexion Canada, but I have been in the patient support world for quite a number of years. I am also a nurse by background and transitioned out of direct health provider into the PSP world.
Hi again, everybody. I'm feeling a bit of deja vu. I should have probably at least picked a different chair to sit in. But so I'm Sandra. I'm the CEO at Neighborhood Pharmacy Association of Canada. What wasn't mentioned the last time I was on a panel, I'm also a pharmacist, and I actually operate an independent pharmacy outside of Toronto, out in Guelph. So I kind of bring both hats of experience there in my perspectives.
Excellent. Thank you. So maybe just to jump in and level set the discussion, create a bit of a framework. Andrea, I'll turn it to you first, just in terms of how these patient support programs, I think we've talked a little bit about this, but why they've evolved the way they have. What healthcare system gaps are we filling with these programs? And again, with that theme of sustainability in mind, what's the utility of the programs in terms of how they've come to this place today?
Yeah, I think it's important to understand the whole evolution of patient support programs as it relates to the healthcare ecosystem as a whole. When PSPs first came out of the gate, it was really changing how the delivery of healthcare was happening. We saw biologics or IV infusible products in a chronic disease state being done in a hospital setting, which also was not sustainable from a hospital perspective, pull out into the community and then provide care closer to the community patient place. Then we saw it evolve a little bit where it became then a cost of entry for manufacturers. It became an expectation from payers that when you came out with a specialty medication, it was an expectation that you had a PSP that followed it. And it almost went to like this one size fits all. Everybody had to do reimbursement. Everybody had to do the infusion support or whatever the needs were around that medication. I think today we're doing the pulse and pressure on PSPs. Where do we go from here now? There's been an evolution on not only is it the reimbursement complexities that the PSPs support physicians, patients, and so forth, not only is it the infusions that are occurring, but we're seeing the diagnostics start to fold in here where we see a fundamental gap across Canada on where diagnostics are covered or not covered. And PSP is playing a pivotal role in making sure these patients are getting the diagnostics they need to support their access, which is also the criteria that's being set from payers. And so with that, we're seeing that the value has switched, or is starting to switch, where it's not so much a competitive advantage, it's not so much an expectation to have one in the specialty space, but it's starting with niche areas that have additional layers and complexities with those products on how the PSP can help support the ecosystem to be able to do that in the best care of patients.
Sandra, I know you're representing the voice of pharmacy, and it's pharmacy operators or pharmacy organizations that are typically involved in running some of these programs, and you've done work through neighborhood pharmacies to better sort of understand the impact and the scope of these. Maybe you can talk just a little bit about that research that's been done. Yeah.
Sure, and I'll just sort of jump on the comments that were made. I mean, it really is, Andrea mentioned it's really filling a gap, and I think that we're in a system right now where health system capacity is so strained. We can't find more time in hospitals. We can barely find time in family physicians. We are, months and months to wait to see a specialist, and so there is a real need for patients to better access care, and we have pharmacists, we have nurses through PSPs who can support patients among other services. And Quinn, you and I were just having this conversation around, what are the services that are really supporting patients, and what's the value? And I think that the reality is PSPs have sort of been created to help support the delivery of so many important services and components that are filling a gap. And you'll excuse me because I'm going to pull up some notes, because I do want to throw some numbers at you guys here, because we at Neighborhood Pharmacies just did last year released a sort of landmark study that looked at PSPs, looked at the value to the healthcare system and to the patients, but also like the monetary value that it brought to the healthcare system, and the savings and the services that PSPs, which are really a partnership between manufacturers and pharmacy and PSP providers, that really drive a lot of value to the healthcare system. So, really demonstrating that gap. We know that only 2% of prescriptions are filled that are specialty, or 2% of all the prescriptions that are filled are specialty, but that makes up 50% of the dollars that are spent. So we know it's a huge area of focus for payers, policymakers, and as we think about the sustainability of the system. 42% of those specialty drugs are cold chain. So while I want to stress that every pharmacy across the country has cold chain capabilities, when we're talking about really high cost or really sensitive drugs, the investment in that cold chain capacity and infrastructure becomes so much more important, because you want to protect and be good stewards of those products, and the money, the dollars that are being covered through public and private payers, ensuring that those drugs do not get spoiled or get wasted. 1/3 of those specialty drugs are infused. So again, you mentioned the need for infusion supports, administration support. The upfront investment that specialty pharmacies are investing to develop some of those PSP infrastructure, like those infusion clinics, the staffing, the cold chain capabilities, is incredible. We estimated it's about $700 million of upfront investment, and then $100 to $200 million annually that's invested just in maintaining some of that infrastructure. Certainly with the cost of the drugs, the inventory considerations and the cash flow considerations between acquisition of product and reimbursement of product is a significant consideration that these pharmacies have to manage. Some really interesting sort of clinical outcomes, because Andrea mentioned the importance of PSPs in supporting patients, not just from a reimbursement standpoint, but from a clinical standpoint, monitoring, adjustments, et cetera, and coordination. Significant value in terms of reducing time to treatment initiation. We found that the patients that were being supported by a PSP had a reduction in time to treatment initiation by up to 60 to 70%. So we found improved adherence rates, 83% more likely to be adherent when you're part of being managed by a PSP, 69% less likely to stop treatment, and 20%, so better patient outcomes generally, 20% more likely to be in remission. So I threw a whole bunch of sort of outcomes type of data at you guys that we found through our research that we did. But in terms of even hours and dollars invested, 9 million hours of clinical services, so approximately $500 million worth of direct patient care, 500,000 hours of infusions hourly. So just thinking about all of those services that are delivered through PSPs and specialty pharmacies and the value of those, but also, do we have capacity to find that kind of time in our healthcare system today? The reality is we don't. So it is serving a really, really important gap today. So yeah, that's what we found.
Terrific. I think, there's a whole other conversation to be had about the reimbursement model for pharmacies and so on that goes along with that investment, but that's a topic for another day. But it does help, I think, articulate or demonstrate, again, the value, the impacts of these programs. When we had our prep call, Quinn, I think, though, you rightly challenged us to think about, we've got this far. We heard in the last panel that there was sort of an expectation from payers of having a certain level of service, but that isn't necessarily easily, when you're coming to market for one of those biosimilars as an example, and you don't know if you're going to get 5 or 50% of market share, but there's a certain expectation of service level, that's really difficult to justify. And you sort of, I think, said, can we think about this difference? What should we be thinking about moving forward? And I know some of your research is focused on that too.
Yeah, I think it's a great question. As you said, I think it's 25 years that this has now been a model, and I think we are coming to a moment where people are starting to look at this from a number of angles, but really, I think it's worth asking the question, is this something that is now just by default? A new product comes to market, it necessarily has to have a PSP. Have we forgotten to ask, what gap or what need is this really filling? And I think I want to call attention to 2 features that we're hearing in our work. So we, as good researchers, tried to do a lit review to figure out, and I think this is the day that I've heard the most talk about PSPs ever. Very exciting, it's a topic, but we couldn't find much. And so we asked the question, even what drugs have PSPs on the Canadian market? And a young nursing student lost a summer of her life going through all the prescription drugs on the market to see if they have a PSP or not, and seeing the kinds of features that they have. And I think we've mentioned education and clinical supports and infusion networks, but overwhelmingly, what these programs are offering is reimbursement, navigation, and financial assistance, including compassionate access, bridging. And so I think what I hear then from patients in interviews, they are willing to enroll in a PSP because it is a lifeline. It is the only way for patients to often afford these drugs, to get them at all. And I think in terms of filling gaps in a system, often what happens, I think, is the industry is filling gaps that shouldn't exist. In our sane patchwork system of drug coverage, affordability, access are issues, and patients are enrolling these because it's the only way to get that treatment. But I think the other thing we haven't, maybe I feel like it's hinted at today, in my interviews with a number of stakeholders, but patients in particular, they often joke that PSP stands for Physician Support Programs. And not to say that physicians don't require support, and they are often, I think, faced with a crushing amount of paperwork, and that is not why they went to medical school. But I think there is also an expectation from prescribers that PSPs will offer certain supports. I think manufacturers are feeling like this is a point of competition. I think it is used as a point of competition. But that is not really putting the patient at the center necessarily, and I think there's really some questions from patients about whether it's appropriate, whether they desire some of these services to be provided by PSPs instead of their physician office, instead of their care team. That said, I think it is very complicated to get into the business of operating health services, and as any nurse knows, you can't leave until your replacement arrives. And so it isn't the kind of thing that I think will change necessarily quickly, and it will require some creativity, including the thinking about the role that pharmacies play, community nursing. This is obviously not the moment to think about asking hospitals to do more.
And I think there's a balance. You make a really good point where patient support programs should be inherent to say patient. I think when you look at the journey of PSPs, there's somewhere along that journey, there's been a flip of how do you provide healthcare closer to the home to now it's an expectation. And it's not only an expectation from you hear payers saying, where's your PSP? Do you have a PSP? But it's an expectation from our clinicians out there because of the burden of paperwork. We're already constrained with physicians out there, the lack of physicians. They're having minimal time with their patients. Yes, they don't want to spend a lot of time. So it begs to challenge the entire ecosystem on how do we do this better? You have physicians with the burden of paperwork. You have patients who get confused. They don't understand the reimbursement landscape 9 times out of 10. We heard it today. They say, I have coverage. And then when you investigate their coverage, they have a max of $10,000, but they've been prescribed an $80,000 a year drug. And so they're left in the unknown and uncertainty on how do I manage my disease. And I think there's inherent pressure we need to start putting back on the ecosystem on how do we fix this? It's not just about PSPs, it's about how do we streamline processes effectively so there isn't a burden of paperwork on physicians, and that includes the expectations from payers. How do we streamline it effectively so there's good transition of care from a hospital setting into the community? And then what does it look like in the community? How do we take children from a setting of care and transition them to adult care effectively, leveraging elements of the PSP, leveraging elements of what the payer can bring to the table? And I think this is something we're all trying to bring this momentum to do because we see the system failures happening, right?
Andrea texted me yesterday in the afternoon about a comment that was made in one of the sessions about the infrastructure doesn't support connectivity, right? And that's huge and fundamental, I think, to this conversation and the gaps that do exist, but also who's needed to overcome those. Like who, and this is a question for all 3 of you, I think, who does need to come to the table in order to both identify, but then potentially address or solve some of those gaps?
I'll just add one more comment to sort of what Andrea and Quinn had mentioned is we do need better systems. I think there's opportunity to better recognize this public-private partnership. There are gaps that are being filled in the system, and I think there's an opportunity to think about, I mean, we as pharmacy always talk about we are not sort of separate to the healthcare system. We are part of the healthcare system. We are part of the care team. And PSP and pharmacy in many ways kind of overlap to some extent, but some of those services are pharmacy services and or pharmacist or nurse delivered services. And so how do we better, build the system and the system infrastructure to better recognize that it's not just the physician and then the PSP, but more so the patient's care team, and that may involve the nurses, the pharmacists, some of the case managers, the physician, and that becomes the patient's team as opposed to these are services the physician should be doing, rather than the PSP or the pharmacist or the nurse. So I think and it sort of speaks to that infrastructure and that system infrastructure because the physicians don't have the capacity to do it all. So how do we better build infrastructure so that there's better visibility, I guess, or transparency of who's doing what and how we're supporting the patients better? And to your question, Chris, I think we have to bring all those stakeholders to the table, and I think policymakers, I think we have to ask the tough questions about funding too, because who's funding these services and how do we ensure that those services are sustainable? And then back to Andrea's comment, or maybe it was Quinn's comment, like it's not one size fits all because every drug has different needs, every patient has different needs, and I think we always argue since the launch of this whole specialty stream, we say specialty implying that every specialty drug fits under this one bucket, but that's not at all the case. And that's why there's no definition for specialty drugs because they are all completely unique, whether it's because of their price point or their clinical requirements or their administrative compliance requirements. So I think there's lots of questions we need to ask and align on, I guess.
I agree. I think there's also, to your point, a lot of variability, whether you're in a crowded disease state area where there's maybe 8 to 10 molecules on the market versus in a disease state area that you might be the lone stander, right? And then you have to segment in those areas. I think to your point, Quinn, what are the gaps in those areas? So we get away from, it's not a one size fits all, but can we target what's truly important to the patient and truly going to help us drive better outcomes for the patient, right?
I'll maybe jump in. I think if we're thinking about it as a patient support program, what we're trying to understand in our research is really what is the patient's experience? What does it look like to move with your chronic illness through this? And one thing that I guess I didn't anticipate before I started this work is that many of these people with serious chronic conditions are going to be on 5, 6, 7 more biologic, biosimilar therapies that all come with a different patient support program. So they're transferring in, they're transferring out. I think having a serious chronic illness is like having a part-time job, sometimes a full-time job. People are already and have always had to be their own case manager. But now, in a time where they are experiencing a great deal of suffering, disability, pain, fatigue, they're getting calls perhaps from a doctor's office, from a pharmacy, from a patient support program, from an infusion clinic. They can't always figure out who's who, where to direct their questions, where to direct their calls, and so they talk about having to be the case manager for their case manager. And then, of course, there's the issue that half of these interactions are happening over fax. And the patient is not CC'd on a fax because who has a fax machine? And I'm hearing from patients and patient groups that at minimum the patient needs to be on every communication. If we're thinking even within a PSP, they need to know what was sent to the pharmacy, what was followed up, who submitted the prior auth, because otherwise they're also chasing this down separately. But in some sense, I think we have to think about, does it make sense to organize a health service or a model of care around a particular product when we know that people will take probably and be on multiple therapies throughout their life?
And that's where it comes to the variability, disease state to disease state. Whether you're in a crowded environment where, yes, patients can go through 8 different PSPs. And if you think of it from a patient lens, how many of us would really want to say your story 8 different times? Because every time you go into a PSP, you need to know the story, right? So there's a fundamental gap or fragmentation that's happening there. But if you're in a disease state where there's only one product on the market for you, that's a very different experience for that patient. And many times you see with those patients on chronic therapy, they really formulate strong relationships with their nurse out in the community. So if we go to adjust the model, I think considerations have to happen. What area of disease are we targeting to adjust the model to make this efficient, effective, seamless, and definitely supporting the patient through it?
I think the other example of what you're describing, Quinn, is, I mean, we experienced this with biosimilar transitions, right? Where a patient had a whole team and had a patient support program, and then when they were transitioned to a biosimilar of that product, they experienced a whole change of their team, and it's a whole new experience and a whole new team besides the one that they've sort of developed relationships with or trust with or a system with or a clinic that they regularly visited. So I think that is one of the big challenges in today's model if we were to think about kind of looking forward and what we could be considering in terms of gaps or challenges with that patient journey.
It's interesting, someone asked me the question yesterday, and I hadn't heard this term before, but is there an opportunity or a role for, they use the word co-optition, which is cooperation, but competition still amongst these PSPs, and I think it sort of gets to what I'm hearing here in terms of some of the repeated enrollments over and over again. How do we cooperate to simplify that in the interest of the patient, or is there a way to sort of streamline that process? I know Christian asked a question yesterday too about annual PA or SA, why do we have to do this over and over again if nothing's changed in that clinical profile for the patient? I guess the question for the panelists is there anything else there that's sort of redundant or duplicitous? But I guess moving forward and looking at this again in terms of where do we go from here, are there therapeutic areas where we do need to sort of lean in further, where these PSPs can have added value and can really sort of, again, fill health system gaps that are just emerging or are yet to emerge?
want to start on that one?
I always start. For me, I think there's opportunity. Again, I go back to it isn't just about PSPs, it's about our entire system. Yeah. It goes back to, yes, we're filling out an essay form, and what actually resonated with me in one of the panels yesterday was the person who has an amputated leg, and yet they got to prove it every year, like the leg's going to grow back. I think we live in this world, whether it's payers or PSPs and so forth, and I think there's opportunity, and we need to drive that opportunity and momentum to take a step back and say, my gosh, what's not working here? What do we truly need to lean into and fix? And if it's a therapeutic area that's crowded, that has patients getting scared or nervous because they're jumping from program to program to program, then let's target that. But then let's also target the payers on why are we doing these essays over and over and over again when nothing's changed? Or can we put more impact on the clinician to justify that, like, they're making the clinical decision to prescribe. Do we put more trust there that they're going to discontinue just the same? And so payer, you've evaluated at the beginning, let's all move along here. Because we're creating burden in every step of that pathway that until we all put our heads together and understand every step of that pathway, we're going to continue operating this way. And then we get into the discussion of this is not sustainable at all.
I think it's always useful in health services, health policy research to take a comparative lens and look at other jurisdictions. And in other places where we have universal healthcare, we're not quite doing it like this. And Canada stands out. And I know that manufacturers, when Global comes to visit and you have to explain the line item that is the PSP, that it sticks out like a very, very sore thumb. And so I think that should also give us pause in terms of how we care for people with serious chronic illness that rely on specialty medicines. And since they gave me the microphone today, I think part of the value we see in PSPs is the value of nursing care in the community and the value of pharmacist care, the value of care. And I think features of our system, let's be honest, physicians have never done paperwork. There are other people who do that paperwork, but our fee-for-service model doesn't support, having clinical nurse specialists in the community to provide holistic chronic disease care, to reimburse the pharmacy for the care that they are providing at that busy counter. And I think these are things we can advocate for. Our hospitals certainly are struggling. But I think in Canada, we haven't even begun to look very robustly at what holistic chronic disease care close to where people live, work, and play can really look like. And I think the industry has been patching these holes, and sometimes the danger in patching the holes is that they become a lot less visible.
And I think the other part of it, and this is really a lot of the work that we do at neighborhood pharmacies and why we sort of did this research, is helping payers understand some of those services, because these services are complex. There are lots of them. They are not one size fits all. They are different for each patient. They are different for different drugs. Some drugs need, one service, others need 20. And so I think a big part of it is helping payers and policymakers understand the breadth of these services and reimburse them fairly, because I had a conversation with an ADM recently, and I sort of shared some of these services. And this is an ADM who has been, pushing to drive down reimbursement on high-cost drugs for a long time. And when I started to get into the details of some of these services, he said to me, "Oh, you're really making a case for, better reimbursement for specialty drugs." But the reality is there is really low, like a lack of visibility into some of these services, and I think that is maybe a disservice that the sector has done for itself, with good intention to support patients and to help funding and to help provide additional services, but because we've continued to do that, and frankly do it pretty well in many cases, we haven't really shone a light on what the gaps are that we're filling, as you said, Quinn, and there really is not a good understanding. So when I was speaking with this ADM, he sort of said to me, within the ministry, we really look at this as, slap a label on, pull it out of the fridge, and pass it on. And so naturally, and I would presume a lot of payers are thinking the same, and we're seeing dollar caps, we're seeing reduction in margins, and those margins are really what pharmacies operate on primarily to fund a lot of these services. Understandably, PSP sort of a different bit of funding, but when you look at both of those together, there's a lot that is really under attack and that's not sustainable. And I think we need to start kind of opening that up and looking at some of those services to find a way to fund them more sustainably.
Yeah, one more question, and then we'll go to the audience for input. But Quinn, you referenced nursing, Sandra, pharmacy. How is scope of practice maybe playing a greater role to offset some of these things? And then Andrea, where's the science going? Like, what are some of the things we anticipate as needs in the future patient support programs that may be more complex?
Do you want me to start this time? Okay. But now I'm gonna steal some of your thunder. But some of the things that for pharmacists, for example, adaptation of dosing and monitoring. We're seeing a lot more provinces enable pharmacists to be able to order labs and do point of care testing, which can support ongoing therapy monitoring, but also initiation. So whether there's any sort of pre-initiation testing or diagnostics or genetic testing that might consider appropriateness of therapy, safety of therapy. So there's a lot of opportunity to consider pharmacists and the role they may play in that space. In addition, a lot of provinces are now enabling pharmacists to do administration of drugs. Administration of drugs, basically. So there's an opportunity to consider, specifically for subcutaneous, I don't think for infusions quite yet, but looking at anything that is, subcutaneous or anything like that. Pharmacists are getting the scope to be able to do that in community now, not only for training, but also for the administration itself. But I do want to stress that while pharmacists' scope is expanding, a lot of that scope is not necessarily funded, and pharmacists are struggling with the same challenges as the rest of the healthcare system. And so while we are well positioned to continue to take on more services, we need to be able to staff up and resource accordingly. And so the more services we can take on, we also need to make sure there's appropriate funding for those services.
Winner.
Andrea? Oh, do you want me to go?
Whichever.
No, I couldn't agree more. It does come down to who's funding it, who's going to pay for these additional scale and scope, whether it's in a PSP or within a pharmacy, right? And I think where we're going with specialty medications as we move more into targeted therapies, gene therapies coming in, we're seeing criteria from payers be expansive. I mean, back in the day, an SA form could be 1 page. I will say I saw one not too long ago that was 8 pages. And so, yeah, that is a burden to complete that paperwork from 1 page to 8 page, but the criteria being requested can also be quite extensive and not necessarily feasible in this system, hence why I think future forward, we're seeing the diagnostics come into whether it's a pharmacy or a PSP world to coordinate. Some diagnostics aren't covered in Canada. Some diagnostics you actually have to ship to Europe to get the testing done, right? And how does a physician know how to do that? How do we coordinate that through labs? And I think there's got to be a detailed focus on it. For me, it comes back to the product, the disease area, and what the needs are specifically in that disease area that's going to drive and shape where we go as an ecosystem as a whole. Because I think there's opportunity in some areas to create a different approach. In other areas, the complexities, I think, can be really tough. One that does need whether it's a PSP or extended pharmacy role support to help enable some of those things.
Anything you wanted to add?
Yeah, I mean, on the scope of practice thing, I think this is what nursing does. This is our wheelhouse. I think community nursing particularly is perhaps less visible than what we see in acute care. I think we've invested less in community care in general. I think many of the companies represented here are employers of nursing workforce that are doing this work through PSPs. But I do think sometimes their full scope is actually constrained by some of the structures of PSP. For example, only being able to see a medical record that pertains to the person when they took that drug. You don't get a whole picture, or you're the nurse in the infusion clinic, you can only see what's in front of you, but that person, that whole person and their whole life and whatever's going on does show up at that door. And I think that's where we really see the expertise of nurses, whoever they work for, come through to make that situation work. And I think that's where we're not seeing them working to their full scope, because they're not interested with the care of that whole person and their whole condition.
Do you think that's also part of our system in general? And I say this because you can have a patient who has had some diagnostics done in Northern Ontario, but then all of a sudden they're referred to a hospital in downtown Toronto, and there's not access, right? So we have a disconnect even in our systems. Absolutely. On how do you create that whole person lens that has to be fixed.
Yes.
Forget Northern Ontario to downtown Toronto, one hospital or one, across the street. And pharmacy to pharmacy, and pharmacy to, PSP or specialty pharmacy. There's massive gaps in, patients' access to their own records and healthcare providers.
And it becomes a challenge when a payer's, asking for specific criteria, and the specialist seeing patient doesn't have what the payer is wanting, and everybody's trying to figure out how do you get it, right? The payer says, no, I have to have this. Physician says, I don't have that result. And the physician's trying to find it. And then we run into this access challenge. Great, now we've got delayed access because we have no connectivity.
Yeah.
Wonderful. We're pushing up against the end of our time here, but want to make sure we have an opportunity for any questions from the audience.
Quiet.
Any?
Everybody's tired.
Everybody's getting
Yeah.
tired. Yeah.
The PSP discussion has run its course.
Exhausted.
Excellent. Well, with that, then we'll leave it there. I want to say thanks to the panelists. We really appreciate the discussion. I think this has been fruitful, and we'll take a couple extra minutes for break. Thanks, everyone.
Thanks.
Thank you. That was great.
Again, thank you to the panel, and as you heard, it's break time. Get jacked up on coffee and get ready to come back for one more little keynote and one last panel.